Good afternoon, everyone. Today I'm going to talk about pharmacotherapy of schizophrenia. So, antipsychotic drugs I'm going to talk in detail. And schizophrenia is your heterogeneous syndrome. It is characterized by perturbations of language, perception, thinking, social activity, affect, and volition. There are no pathognomic features. This syndrome occurs in your late adolescence and has insidious onset. Okay, the onset. If you talk about the onset, it occurs in a late adolescence and has insidious onset. So it is not acute onset, and they have poor outcome as well. So the poor outcome occurs from your social withdrawal. They will withdraw from their families, and they have perceptual distortions to recurrent delusions and hallucinations. In these patients, we have two types of symptoms: positive symptoms and negative symptoms. The positive symptoms, we have delusions, hallucinations, and conceptual disorganization. If you talk about the delusion, it is firm and false belief is called delusion. And hallucination is some images appearing in front of you. For example, a snake is moving in front of you. That is called hallucinations. Hallucination is different from illusionation. Illusion is like an rope up in front of you is appearing like a snake. But hallucination, even if there is no rope, a snake is found to be moving in front of you. That is called hallucination. So image appearing in front of you. Okay, that is hallucination. Negative symptoms, if we talk about that, we have loss of function, anhedonia. Anhedonia means they cannot feel pleasure. Okay, they cannot feel pleasure in their life, and they have decreased emotional expression, impaired concentration, and diminished social engagement. And these patients should have at least two of these symptoms for at least 1 month period. Okay, for a diagnose to make the diagnosis of schizophrenia, they should have at least two of these positive and negative symptoms for a 1 month period, and a continuous sign should be there for at least 6 months to meet the formal diagnostic criteria of schizophrenia. So there is also called catatonia may also be present. Catatonia means there will be disorganized thinking or speech or grossly disorganized motor behavior. That is called catatonia. So as individual progress, age is progressing, then positive psychotic symptoms will tend to control or attenuate, and some of your social and occupational function may also be regained. But in case of negative symptoms, it is more dangerous comparing to your positive symptoms because it predominates in one third of your schizophrenic population, and it is associated with poor longer outcome, and it has a poor response to drug treatment. That's why the negative symptoms are more dangerous because they are not treated properly, and they have very poor outcome, and they have poor response to drug treatment. So there will be marked variability in the course of your schizophrenia, and depending upon the individuals, it is varying. Okay, and catatonia, if you talk about only the catatonia, it is a non-specific syndrome. It occurs as a consequence of several psychiatric or medical disorders. It is diagnosed by documentation of three or more of cluster of motor and behavioral symptoms. So it's a mainly motor and behavioral symptoms. So we have to see these symptoms like stupor, cataplexy, mutism, flexibility, and stereotypy. Okay, stupor, cataplexy, mutism, flexibility, and stereotypy. This is called catatonia. And prognosis depends upon not on your symptom severity, but it depends upon how your response to the antipsychotic medications. So prognosis depends not on your symptoms but on your response to antipsychotic medications. Even a permanent remission can occur without occurrence. It can occur very occasionally, and about 10% of your schizophrenic patients may commit suicide because of negative symptoms and depression. And you have to talk about your dopamine connections in your brain. There are four pathway. Okay, you have to remember those things: tubero hypohysial pathway, nigrostriatal pathway, you have learned it in Parkinsonism, mesolimbic pathway, and mesocortical pathway. In psychiatry, schizophrenia is due to over dopamine in increased dopamine in mesolimbic pathway. Okay, that is why they have more dopamine and more psychosis. Remember that point: more dopamine, more psychosis, especially in the mesolimbic pathway. And mesocortical pathway dysfunction is responsible for your negative symptoms, cognitive deficits. And mesolimbic overactivity is called positive symptoms. So mesolimbic pathway overloading is called positive symptoms. Okay, and mesocortical dysfunction causes negative symptoms. And nigrostriatal pathway lead to Parkinsonism, and tuberohysial pathway lead to galactoria, hyperprolactinemia, like that. So if you see the connections, their mechanisms. So dopamine tract nigrostriatal pathway origin from your substantia nigra, and it is innervated in your striatum. And function is movement. Okay, the movement. So in case of Parkinson's, there will be bradykinesia, reduced movement. So remember that. So more dopamine, more movement. So in mesolimbic pathway, it is connecting from ventral tegmental pathway, which is present in midbrain, to nucleus accumbens or amygdala, area of limbic system. So nucleus accumbens is responsible for your arousal, stimulus processing, motivational behavior. So it is also concerned with your processing, arousal, stimulus. Okay, like your reflex pathway, arousal, like that, motivational behavior. And mesocortical, C for cognition. Remember, cortical for cognition. So it is also starts from the ventral tegmental pathway, but it is connected to your cortical. Cortical is cortex, prefrontal lobe cortex and frontal cortex. So they have cognition, communication, social function, and response to stress. They are taken care of by your mesocortical pathway. And coming to tuberohypohyseal or tuberoinfundibulum pathway, it starts with your hypothalamus to pituitary gland, and this pathway inhibits the prolactin release. But if you are giving dopamine antagonist, there will be increased prolactin, there will cause galactoria and hyperprolactinemia, like that will happen. So nigrostriatal pathway leading for movement, mesolimbic pathway for arousal, stimulus processing, motivational behavior, cortical for mesocortical for cognition, communication, social function, and response to stress. And tuberohypohyseal pathway is for inhibiting your prolactin release. So the positive symptoms is due to overactivity of your mesolimbic pathway, and negative and cognitive symptoms is because of your mesocortical pathway dysfunction. So this is the pathophysiology, and the risk factors are of your schizophrenia or genetic susceptibility and early developmental insults, winter birth. They have reported the babies born at the winter can they have higher risk for schizophrenia also, and increased parental age. Okay, and if your father or mother are very old and they have given birth to a baby, then the children has more possibility to get schizophrenia. And genetic factors are involved in at least a subset of individuals who develop schizophrenia. So it is in monozygotic twins, it is much more common. And schizophrenia is observed in all 6.6% of your first degree relatives of the affected proband. So the schizophrenia prone patients, they also at risk of other psychiatric disorders like schizoaffective, schizotypal, and schizopersonality disorders. Okay. And coming to the pharmacotherapy of schizophrenia, if you talk about the mechanism of action, we have typical antipsychotics and atypical antipsychotics. Typical antipsychotics block the D2 receptors, dopamine receptors in the mesolimbic pathway, and atypical antipsychotics, they will act other than the dopamine pathway. For example, they can block serotonin 5-HT2A receptors. Okay, 5-HT2A receptors. Remember these points in your mind. So in untreated schizophrenia, there will be more dopamine. This blue color is dopamine. There will be more dopamine. So there will be more dopamine in the mesolimbic pathway. So there will be more positive symptoms. So if you are giving typical antipsychotic, there is a D2 blocker. So dopamine will not bind to the dopamine receptors. So there will be reduced positive symptoms. Coming to the mesocortical dysfunction, I have told you because of cognitive deficits. It is responsible for your production of negative symptoms. If you are giving dopamine antagonist in these cases, there will be worsening. Okay, there will be worsening of your negative symptoms. There will be no improvement because more dopamine is responsible for your cognitive function in prefrontal cortex. If you are giving dopamine antagonist, it will decrease the dopamine and it will worsen your negative symptoms. Here, the dopamine should be overloaded. Increased dopamine is essential for your protection from your negative symptoms, and it helps in cognition. If you give dopamine antagonist, it will worsen your cases. So, extrapyramidal symptoms, if you talk about that, the dopamine will bind to it actually. If you are giving dopamine blockers, what will happen? Dopamine will not bind, so the dopamine and acetylcholine balance will be altered. Since dopamine is not binding, the dopamine will be low, and cholinergic symptoms will rise. Because of increased in cholinergic activity, you will get extrapyramidal symptoms. So you should give anticholinergics in such cases. Centrally acting anticholinergics because it is in your brain. Okay, so like benzhexol you can give benzhexol, procyclidine, piperidine, benztropine, like such drugs you can give. So pathophysiology of tardive dyskinesia. So if you are blocking the dopamine receptors for long time with typical antipsychotics, there will be upregulation of new dopamine receptors will happen. Okay, even that will be sensitive to even a small amount of your dopamine. Okay, so very sensitive because of upregulation of the dopamine receptors. Because of blocking dopamine receptors, there will be upregulation of new receptors. Okay, and that will lead to tardive dyskinesia. And the latest drug approved for tardive dyskinesia is tetrabenazine, VM82 inhibitor. Okay, tetrabenazine and valbenazine. I have told you that if you are blocking the dopamine receptors with antipsychotics, what will happen? There will be increased prolactin release in your tuberoinfundibular pathway. That will cause catatonia and hyperprolactinemia. So other problem with your conventional or typical or first generation antipsychotics is they can also block your along with blocking dopamine receptors, they also block your anticholinergic muscarinic receptors. They can also block the muscarinic receptors, antihistaminic activity and alpha 1 blocking activity. Alpha 1 blocking activity will cause postural hypotension, and histamine blocking will cause sedation, and anticholinergic activity will cause anticholinergic side effects like dry mouth, constipation, urinary retention. Such activities will happen, and blurring of vision because of mydriasis. And because of anticholinergic activity, you will get constipation, dry mouth, drowsiness, and blurred vision because of mydriasis. This is about your extrapyramidal symptoms. For example, if you are blocking the dopamine receptors, there will be we are not blocking. This is just a dopamine is binding to the dopamine receptors. If there is more dopamine, there will be decreased cholinergic. Okay, there will be decreased acetylcholine. If you are blocking the dopamine, there will be increased cholinergic, there will be increased acetylcholine, causing extrapyramidal symptoms. So that's why how you treat the extrapyramidal symptoms, you have to give anticholinergics so that the acetylcholine will not bind to the cholinergic receptors. And first generation drugs can also block your dopamine receptors. Second generation drugs, some drugs like risperidone, clozapine can also block you. Risperidone can block your dopamine receptors, not clozapine. And aripiprazole have agonist action. They have partial agonist action as on the dopamine receptors. So first generations like haloperidol can block your dopamine receptors, and second generation drugs, only few drugs like risperidone can block your dopamine receptors, and aripiprazole has partial D2 partial agonism activity on your dopamine receptors. And your second generation drugs, the atypical antipsychotics like your clozapine, they also have very high affinity for your H2A, okay, 5-HT2A, HT2A, 5-HT2 receptors. They can also block your 5-HT2 receptors. That is the main mechanism of action. But they can also block your dopamine receptors but have very lower affinity, like risperidone. They can also block your dopamine receptors but they have very low affinity comparing to your first generation drugs like haloperidol. So what is the reason for blocking your 5-HT2A receptors? That will, by blocking your 5-HT2A receptors, there will be increased dopamine release in your prefrontal cortex. So prefrontal cortex, it is present in your mesocortical pathway. Okay. So mesocortical pathway, because of increasing the dopamine release, you can treat your negative symptoms. Okay. So it is better than your first generation drugs. First generation are D2 blockers. So decreasing the dopamine release in PFC will aggravate your negative symptoms. But these second generation drugs, they are increasing your dopamine release in your prefrontal cortex. And if you talk about their dissociation, okay, the second generation drugs, they dissociate rapidly from your D2 receptors. And first generation drugs, they bind very tight to the D2 receptors. And clozapine and other second generation drugs, their binding to the dopamine receptors are very loose. So this is the picture of binding of second generation drugs to the dopamine. First they bind and they will immediately come out of these receptors because of dissociation. And dopamine will bind to it. You know that. And other specialty of second generation drugs, they are also 5-HT1A agonist. These 5-HT1A agonism and 5-HT2A antagonism, they both of them thought to increase your dopamine release in your prefrontal cortex and reduce your glutamate release. The second generation example are ziprasidone, quetiapine, and clozapine. So as a summary, first generation antipsychotics, the main property is D2 antagonism, and second generation antipsychotics, they also have D2 antagonism, but they have very rapid D2 dissociation. Their main mechanism of action is 5-HT2A antagonism and 5-HT1A agonism. They thought to increase your dopamine in the prefrontal cortex, so they can take care of your negative symptoms also. And other effects, side effects, we told you, they block your muscarinic receptors, anticholinergic side effects, antihistamic activity, alpha 1 blocking activity. Second generation also have these activities, but in milder form comparing to your first generation drugs. So now what are the drugs we have? We should see it. So we have in first generation drugs, we have low potency, mid potency and higher potency drugs. So low potency drugs, we have chlorpromazine and thyroidazine. And chlorpromazine and thyroidazine are responsible for your anticholinergic effects. And they can also cause your QT prolongation because of alpha blocking activity. They can cause orthostatic hypotension. So these problems are present in your low potency drugs. And the low potency drugs you will not have extrapyramidal symptoms. They don't have very high D2 blocking activity. And in high potency drugs they are having very high potency to block your dopamine receptors, so they can cause your extrapyramidal side effects. So extrapyramidal side effects are common in your high potency drugs like haloperidol, fluphenazine and thiothexine. In low potency drugs, other side effects like anticholinergic side effects and alpha blocking effects, QT prolongation, photosensitivity, they are common in low potency drugs. And chlorpromazine can also cause jaundice, cholestatic jaundice. Their specialty C for C. Okay, cholestatis chlorpromazine. And mid potency drugs, they are very much tolerated by most patients like trifluoperazine, perfenazine, loxapine, molindone. They are well tolerated by the patients. And advantage of molindone is they have very little weight gain. They can weight loss is the side effect, so it will not cause weight gain like other antipsychotic drugs. So low potency drugs we have chlorpromazine, thyroidazine, and mid potency drugs we have trifluoperazine, feftinazine, loxapine, molindone, and high potency drugs we have haloperidol, fluphenazine, and thiothexine. In second generation antipsychotic drugs we have clozapine, risperidone, olanzapine, quetiapine, ziprasidone, aripiprazole, paliperidone, iloperidone, acinapine, lorasidone. So clozapine is the atypical antipsychotic drugs. It is the prototype drug. It is used in drug resistant cases. Okay, I will explain all of these drugs individually. Just I will mention the drug name alone. Risperidone, olanzapine, quetiapine, ziprasidone, aripiprazole, paliperidone, iloperidone, acinapine, and lorasidone. And rest of the drugs, coming individual profile of the drugs, we'll discuss in next class. Thank you.